بسم الله الرحمن الرحيم. أنا الدكتور طه الهاشمي، أستاذ محاضرة في الأشعة التشخيصية ورئيس قسم الأشعة التشخيصية والتداخلية في كلية الطب بجامعة زنتان. So I am Dr. Taha Mehemed. I am the lecturer and head of department at the Diagnostic and Interventional Radiology department in the Faculty of Medicine, University of Zintan, Libya. Today I'm going to talk about the radiological features of COVID-19 pneumonia. We'll give a little bit of an introduction about COVID-19, and then I will talk about the radiology department precautions and the imaging features of COVID-19 pneumonia on chest X-ray and CT, then using CT to diagnose COVID-19 pneumonia, and how to report CT scans of COVID-19 pneumonia in a standardized reporting system. And then I'll talk about the artificial intelligence and its role in diagnosing COVID-19 pneumonia, and I will summarize some take-home messages. So, COVID-19 is a viral disease caused by SARS-CoV-2 or severe acute respiratory syndrome coronavirus 2. This is the name of the virus. COVID-19 is the name of the disease. The diagnosis is made by a positive PCR test, which is highly specific, while CT has higher sensitivity but lower specificity and can play a role in the diagnosis and treatment of the disease. The clinical features of COVID-19 are usually fever, cough, and shortness of breath, but sometimes abdominal symptoms and other upper respiratory tract symptoms are possible, and the disease can be also asymptomatic. The overall mortality rate is 2.3%. Illness severity can vary from mild to critical. Mild disease will have no symptoms, mild coughing or just fever. Severity or severe disease, they will have dyspnea, hypoxia, or more than 50% lung involvement on imaging. In this presentation today, we will show how to calculate the lung involvement in something called the CT scan score. Okay, the critical cases will unfortunately have respiratory failure, shock, or multi-organ failure. The transmission of COVID-19 is primarily spread person to person through respiratory droplets by sneezing, coughing, and contact of infected surfaces. The viral load is high in the early stage of the disease, and the virus has an incubation period of less than 14 days after exposure. To diagnose COVID-19, according to WHO, the reference test is the real-time PCR test, which is very specific but has very lower sensitivity of around between 65 to 95%, which means that the test can be negative even when the patient is infected. Another problem is that you have to wait for the test results, which can take more than 24 hours, and false negatives are a real clinical problem, and several negative tests might be required in a single case to be confident about excluding the disease. Laboratory tests will show lymphopenia, increased prothrombin time, and increased LDH with mild elevations of inflammatory markers such as CRP and ESR, and also elevation D-dimer can be seen. Nomenclature of the naming of the disease in mid-February, the WHO decided to call the disease COVID-19. So CO is corona, V is virus, D is disease. COVID-19 is the name of the whole disease caused by the coronavirus, SARS coronavirus 2, and COVID-19 pneumonia is what we are dealing with in the radiology department. So we use CT to diagnose COVID-19 pneumonia. Another name for COVID-19 pneumonia is novel COVID-19 infected pneumonia, or NCIP. Some literature use this abbreviation NCIP, so it's the same disease. Okay. Now we'll talk about the radiology department precautionary measures and infection control, and how to minimize the possibility of spreading the disease from patient to patient and from patient to doctor or technologist or the nurse. So the WHO recommends using respiratory protection with the use of a standard medical mask, while the CDC recommends using an N95 mask or higher when in close contact with patients that have confirmed or are under investigation for COVID-19. Droplet precautionary measures in the form of a fluid-resistant gown and a pair of disposable gloves with coverage over gown cuffs, eye protection with goggles, and probably a face mask over the goggles. As for the machines, the CTR machine gun and MR, if we use the MR to image a COVID-19 patient, the gantries and the non-invasive ultrasound probes, anything that we use or becomes in contact with the patient should be disinfected after each contact with a suspected or confirmed patient. According to the Spalding classification of the CDC and FDA, these surfaces need to be either washed with soap and water or decontaminated using a low-level or intermediate-level disinfectant, such as ethyl alcohol, which is very common and readily available in all of our hospitals. So you just wipe it, the surface, that's it. But also you should ask your equipment vendors what is the safest disinfectant to use for each equipment, some equipment, to minimize the damage for these equipments. This article here is very informative and I advise everyone to read it. It's published in, I think, this month in the Journal of the American College of Radiology. So it's coronavirus outbreak, what the Department of Radiology should know. And this diagram, plus the previous two slides, the info is, I tried to summarize from this article. So in this diagram, they say that you better image the patient using portable imaging equipment, and the patient should wear a surgical mask whenever entering or leaving the radiology department. The medical staff should have disposable fluid-resistant isolation gown, eye protection with face mask, and the N95 according to CDC, and the goggles. Plus, you should have disposable gloves with coverage over gown cuffs. Okay, for the equipment as I just mentioned in the previous slide. This special report in the Japanese Journal of Radiology that just came out, I think a week or two ago. It was accepted in the beginning of March. So this is an infection control protocol inside the computer tomography suites. So I think this is very informative and very clear. It's the guideline is very easy to follow. I highly recommend that we adopt this kind of protocol in Libya. So what they suggest is that we need two technologists. One is operating the console and the other is with the patient, setting up the patient on the CT scanner table. So the one who would need personal protective equipment is the one who is in the CT scanner room, and that we will call him a radiology technologist number one. So what kind of protection equipment? Eye protection such as goggles, N95, again similar to CDC recommendations. Here they add a surgical cap and also the gloves, fluid-resistant gown, and shoe covers. So the technologist will be covered from head to toe with disposable personal protective equipment. And so this is a scheme showing the setting at which a patient is being imaged. So this is the patient on the CT scanner table. In the CT scanner room, you will have the radiology technologist number one, who is wearing complete personal protective equipment with the clinician who brought the patient. They both will be wearing personal protective equipment. But in the console room, you will have the technologist number two. And why do we need two technologists? Is because we cannot risk getting all of our technologists being infected and then nobody will operate our machines. Instead of technologists, we can ask some nurse or even some GP doctor who show them how to set the patient. The protocol for chest CT imaging at the CT, chest imaging at the CT suite. So the steps, so let's say a patient came to the department, the patient is suggested, is suspicious of being COVID-19 or clinically proven to be COVID-19. What will happen? So what will happen is as follows. The technologist number one will wear his PPE and will stay in the CT scanner room on standby. the patient with the attending medical doctor will arrive inside the CT scanner room. The doctor will be wearing, of course, his PPE. Technologist number 1 and the MD, they will set up the patient on the CT imaging table. The technologist number 1 and the MD will remove and discard their contaminated PPE inside the CT scanner room and perform hand hygiene and leave the room. After they leave the room, the technologist number 2, who's on the console operating the CT scanner, will image or will perform non-contrast chest CT scanning, while the technologist number 1 and the medical doctor, they put on new personal protective equipment outside the CT scanner room. After the CT scanning, the technologist number 1 and the medical doctor, they transfer the patient from the CT imaging table. Then the patient with his doctor, they will leave the CT scanner room, and the CT scanner and the console rooms are sanitized, as I mentioned in the previous slides, by wiping all the surfaces with alcohol. And also it is suggested that after leaving the CT scanner room, that the room, if you have a negative air pressure, should be closed for 1 hour so that the air will be recycled. But in some recommendations, like the experts panel in RSNA, they say that they will just leave the door open passively for air to change for an hour also. Okay. So this is a scheme showing the steps that we just mentioned. So in the CT scanner room, you have technologist number 1. In the console room, technologist number 2. This technologist is wearing his PPE, waiting for the patient and the doctor to arrive. So in the next step, they are both, the 3 of them are in the scanner room. So the technologist and the doctor will put the patient on the table. Then what they will do is remove their PPE and wash their hands and leave the room. Okay. Then the technologist number 2 will perform the scan. After that, they will go, before going back, they will change into new PPE and go back into the room to remove the patient from the table. Then the patient with the MD will leave, and the technologist will stand by waiting if there's another patient. Otherwise, disinfection of the room. For example, if we have a CT dedicated just for COVID-19 patients, of course, disinfecting the machine is very important, but maybe to rationalize the use of PPE, maybe this technologist will stay waiting in the room. This article is quite informative also. You can also watch the webinar, the video recording of the discussions that happened. You will find it in the website of Radiology Journal, and they also recommend similar recommendations to what we mentioned before. So to image the patients, the CT protocol should be non-contrast chest CT unless IV contrast medium is indicated. But I think a few days ago there have been reports that if you are going to do CT angio, for example, better do the non-contrast chest CT first, because the ground glass opacities might be not seen if you image the non-contrast later on. Okay, so if you suspect the patient has COVID-19, better do a non-contrast chest CT before any other imaging. Okay. Now we will talk about the radiological features of COVID-19. So first on chest X-ray findings. So the chest X-ray is relatively insensitive early in the disease. It's very difficult to visualize ground glass opacities that are seen clearly on CT scans, but you can just a normal chest X-ray in this patient. Okay, this is just 1 hour before the CT. But they can be useful in follow-up of the cases and to minimize, for example, we don't have to keep on imaging the patients with the CT once we have confirmed or suspected. If the patient is in a critical condition, you will see many changes, and the clinicians will deal with the respiratory distress syndrome that the patient is suffering from. Okay. What's more important for us is CT findings. This article, review article here, it's a pictorial review. It was just published, I think, last week. It's very good, very informative, and I will base most of the first half of my CT findings part on it. So what they did is they read every article and about COVID-19 imaging, and they summarized all the changes that have been seen in COVID-19 patients. All of these are the changes that you can see in COVID-19 patients' CT scans. We will go one by one. So first, the most common is the ground glass opacities. What are ground glass opacities? They are hazy areas with slightly increased density in lungs without the obscuration of bronchial and vascular margins. Okay? So it's just a hazy area. And they are, in COVID-19 patients, they can be unilateral or bilateral, more commonly bilateral, peripheral and subpleural, and posterior more than anterior, and more in lower lung lobes. And it is considered the most common imaging finding, with an occurrence rate of up to 98% of cases of COVID-19 imaged by CT. Why does this ground glass opacity happens? I think a recent post-mortem biopsy study has shown that it's pulmonary edema and hyaline membrane formation in both lungs, which might be the underlying pathological driver of the ground glass opacities. They are also commonly accompanied by other features and patterns, including reticular, interlobular septal thickening and consolidation. Ground glass opacities with consolidations are the most common findings you can find in CT of COVID-19 patients. This 35-year-old male COVID-19 patient was presenting with fever and headache for 1 day. The CT scan showed a pure ground glass opacity in the right lower lobe, and it's a hazy lesion that you can see through it. You can see the vascular structures inside it, so it doesn't completely obscure the vascular margins. Okay? Consolidation, which is the second most common lesion that we can see in chest CT of COVID-19 patients. The consolidation refers to alveolar air being replaced by pathological fluids, cells, or tissues, manifested by an increase in pulmonary parenchymal density that obscures the margins of underlying vessels and airway walls. Consolidations are often multifocal, distributed subpleurally, and along bronchiovascular bundles in cases of COVID-19. And usually it's considered as an indication of disease progression. So if we have follow-up images, first you will see, most probably you will see ground glass opacities that will progress into consolidations. Okay. So in this 47-year-old male patient of COVID-19 presented with fever for 7 days, you can see peripherally located subpleural in the posterior area of the right lower lung lobe. So usually peripheral subpleural. This is most of the lesions of COVID-19 are peripheral subpleural posterior and in lower lobes. The next pattern is the reticular pattern, which is defined as thickened pulmonary interstitial structures such as interlobular septa and intralobular lines. And it can be seen as innumerable small linear opacities on CT. This is the third most common pattern that can be seen in COVID-19 patients. As the disease gets longer, the prevalence of reticular pattern could increase in COVID-19 patients, according to some studies. So this is a 34-year-old female COVID-19 patient presenting with fever and dry cough for 2 days. The CT scan shows slight reticular pattern in the left lower lobe, and also again subpleural and peripheral. Okay. The next pattern is the crazy paving pattern, which is thickened interlobular septa and intralobular lines, which are superimposed on a background of ground glass opacities, resembling the paving stones. It was not as frequently observed as ground glass opacities and consolidation, and it may indicate the progressive stage or the peak stage of the disease, in combination, of course, with diffuse ground glass opacity and consolidation. So what is crazy? This is an 81-year-old female COVID-19 patient presenting with fever and cough for 7 days. The CT scan shows a reticular pattern superimposed on background of ground glass opacity, resembling the sign of crazy paving stones in the right middle lobe. As seen here, again, peripheral and reaching the subpleural. Air bronchogram is another sign that can be seen in COVID-19 patients. It was defined as a pattern of air-filled, which is low attenuation bronchi on a background of an opaque, high attenuation airless lung. But according to the autopsy studies, the bronchus was filled with gelatinous mucus instead of air, which would also give a low attenuation, resembling an air bronchogram. It was often accompanied by slightly bronchial dilatation, and maybe the more appropriate term is to call it bronchiectasis. As for why the patients have a dry cough, even with the presence of a mucus-filled bronchus, is maybe explained by the high viscosity of the mucus and the damage of the dilated bronchioles, resulting in insufficient sputum motility. So this is a 48-year-old male COVID-19 patient presenting with fever for 5 days. The CT scan shows bilateral ground glass opacities in the lower lobes and an air bronchogram in the right subpleural area. Airway changes, what we mean here is bronchiectasis and bronchial wall thickening. It was reported in around 10 to 20% of COVID-19 patients, and this is a 66-year-old male COVID-19 patient presenting with fever and cough for 7 days. The CT scan shows a reticular pattern in the subpleural areas of the, so we have a reticular pattern, subpleural, bilateral, lower lobes, and we have ground glass opacity, again subpleural, peripheral, with the bronchial wall thickening seen here by the eye. Pleural changes, mainly pleural thickening. It's more prevalent than pleural effusion. While a recent study showed that 5% of the patients showed pleural effusion and 32% of them showed pleural thickening. And based on previous studies of the last coronavirus epidemic, which was the Middle East Respiratory Syndrome, the presence of pleural effusion may suggest a poor prognosis in COVID-19 cases. Okay. So this is an 80-year-old female COVID-19 patient presenting with fever for 7 days. The CT scan shows the left pleural thickening as shown by the arrows. This sign is the subpleural curvilinear line. It was also mentioned in the same study, the one with 81 patients. It's defined as a thin curvilinear opacity with 1 to 3 millimeter thickness lying less than 1 centimeter from and parallel to the pleural surface. It was reported in around 20% of the patients, which might relate to pulmonary edema or fibrosis. So this is a 43-year-old female COVID-19 patient presenting with fever and chills for 5 days. The CT scan shows the subpleural lines as indicated by the arrows. Here it's a line of 1 to 3 millimeter thickness following the pleural. Fibrosis or fibrous stripes were also observed in COVID-19 patients, and there is a debate about the presence of fibrosis. Is it indicating good prognosis and healing, or in some articles the authors would indicate that fibrosis may indicate a poor outcome of the COVID-19. Maybe they say that the presence of fibrosis will lead that the disease will progress in the peak stage or result in pulmonary interstitial fibrosis disease. So this is a 66-year-old female COVID-19 patient presenting with cophomyalgia for 7 days. The CT scan showed bilateral ground glass opacities and fibrous stripes in the left lower lobe. Vascular enlargement is one of the important signs. We will come later to why it's important. Is often described as a dilatation of pulmonary vessels around or within the lesion on CT images, and it was reported on a PCR negative patient who was admitted to a hospital 6 days after symptom onset. It might be attributed to the damage and swelling of the capillary wall caused by the pro-inflammatory factors. This is a 35-year-old male COVID-19 patient presenting with fever and headache for 1 day. The CT scan shows a large area of ground glass opacities, and in the right upper lobe with multiple smaller vascular enlargements here as shown by the arrows. Okay. The air bubble sign refers to a small air containing space in the lung. It might be the pathological dilatation of a physiological airspace or a cross-section of the bronchiectasis, and it has been reported in COVID-19 patients. This is a 94-year-old male COVID-19 patient presenting with fever and diarrhea for 3 days. The CT scan showed a patchy ground glass opacity with an air bubble sign as shown by the arrow in the apico-posterior segment of the upper left lobe. Another presenting finding is nodules. Nodules are defined as rounded or regular opacity with well or poorly defined edges measuring less than 3 centimeters in diameter. It's been frequently associated with viral pneumonias, and around 3 to 13% of the COVID-19 patients can appear with multifocal solid irregular nodules or nodules with the visible halo sign. This is a 76-year-old female COVID-19 patient presenting fever with cough for 4 days. The CT scan shows an irregular nodule as shown by the arrow in the posterior segment of the right upper lobe. The halo sign or the halo sign was defined as nodules or masses surrounded by ground glass. It has been reported in some cases of COVID-19 patients. In the past, it has been thought to be associated with perilesional hemorrhage in angioinvasive fungal infections or hypervascular metastasis, as well as viral infections and organizing pneumonia. However, the main pathological driver of this manifestation remains unknown at present. So this is what is meant by the halo sign or the halo sign. 46-year-old male COVID-19 patient presenting with fever and dry cough for 5 days. The CT scan shows a solid nodule surrounded by ground glass opacity, or nodule surrounded by ground glass opacity. This is the halo sign. Okay, in the lateral segment of the right middle lobe. The opposite of the halo sign is the reversed halo sign, or also called an atoll sign. So in the center will be less dense, surrounded by consolidation. So it's a focal rounded grounded glass opacity surrounded by a more or less complete ring-like consolidation. It was mainly reported for cryptogenic organizing pneumonia, but in other studies it has been seen in other diseases. Recently, the sign was reported in several COVID-19 cases, which might be attributed to disease progression. It's a late finding that can be seen in COVID-19 patients. Yeah. So the atoll sign, or the reversed halo sign, this is a 66-year-old woman confirmed with COVID-19 presenting with fever and myalgia for 7 days. The CT scan shows a reversed halo sign. So the center is ground glass surrounded by an incomplete ring or a complete ring of consolidation in the right and the posterior basal segment of the right lower lobe. Another finding is lymphadenopathy. It has been reported in around 4 to 8% of patients with COVID-19. Lymphadenopathy is considered one of the significant risk factors for severe or critical COVID-19 pneumonia, along with pleural effusion and extensive small lung nodules might suggest bacterial superinfection over the COVID-19 pneumonia. This is a 49-year-old female COVID-19 patient presenting with chest pain for 14 days. The CT scan shows an enlargement of mediastinal lymph nodes. Another finding that has been reported is pericardial effusion. It's very rare to identify in COVID-19 patients, in around maybe 5% of patients. A recent study showed that severe critical COVID-19 patients showed higher incidence of pericardial effusion than other COVID-19 patients. So, to summarize, what are the most important signs from the signs that we mentioned? Ground glass opacities are the most common, around 88 to 98% of cases. Bilateral involvement is a common feature. Posterior distribution, multilobar involvement, peripheral distribution, and consolidations. These are the most common findings on CT in COVID-19 patients, plus subpleural. So ground glass, bilateral involvement, posterior distribution, multilobar involvement, peripheral distribution, and consolidation. And then comes mixed or reticular changes. Now we will talk about the temporal changes, which means the changes by time. So in each disease stage, what kind of findings we will see early on and at the peak or lung involvement and later on. So this study is one of the best studies that have came out of Wuhan, China, and I have been in contact with Dr. Osama Al-Walid, who's a co-author of this article that was published in Lancet Infectious Disease, I think last month, and their work in this article is very impressive and very good, so I will demonstrate their findings. So what they did is they had 4 groups of patients. They divided the patients that they imaged into 4 groups. The group 1 is the asymptomatic, which was mainly consisted of the medical staff who wanted to check their lungs. That's according to Dr. Osama, that the medical staff wanted to image their lungs. And then group 2 was the patients who had less than 1 week of symptoms. Group 3 were the patients who had 1 to 2 weeks of symptoms. Group 4 who had more than 2 weeks to 3 weeks of symptoms. And these are the imaging findings according to each group. So the groups are according to each stage: asymptomatic, less than 1 week, 1 to 2 weeks, and 2 weeks, so according to start of symptoms. So in asymptomatic patients, they found unilateral, multifocal, or predominantly ground glass opacities. And then in the group 2, in less than 1 week of symptoms, you would see more of bilateral diffuse disease, and the ground glass, the percentage of the ground glass opacities would be lesser than in asymptomatic patients. You will see consolidations and mixed patterns more commonly. So ground glass is still the most common, but you will start seeing consolidations and mixed patterns. Later on, from 1 to 2 weeks of symptoms, you will see less ground glass opacity is more consolidations than reticular pattern, but still the amount of ground glass opacities is more than consolidation than reticular pattern. Then later on, we'll see more consolidations and mixed patterns and much less ground glass opacities. Bronchiectasis, thickening of the adjacent pleura, and pleural effusion may appear at this stage. So this is a diagram from their paper, and here you have the groups. Group 1, the asymptomatic. Group 2, for less than 1 week. Group 3 is 1 to 2 weeks. Group 4 is 2 to 3 weeks of symptoms. So in group 1, most commonly is ground glass opacities, seen as blue here, and this is consolidations. So more than around 90% of the cases were ground glass. As the disease progresses, before 1 week, you will start seeing more mixed opacities, and the ground glass is lesser. Then more consolidation in the peak involvement of the disease from 2 to 3 weeks, and less ground glass. We will start seeing reticular opacities also. Then at 2 to 3 weeks, as the disease progresses, you will see less ground glass, more mixed, and the consolidations are less than the peak, 2 to 3 weeks. So this is the number of involved lung segments at various time points from symptom onset. So as we said, this is group 1 is the asymptomatic. This is less than 1 week, 1 to 2 weeks, 2 to 3 weeks. So in many studies, they have the peak involvement of lung segments has been chosen around day 10, from 5 to 11, but usually day 10 is considered the peak lung involvement, and this coincides with this study. As you can see, from 1 to 2 weeks, starting around the 10th day, the lung involvement is at its highest form, then it will decline again. Also, they have noticed that their patients are 3 types. So type 1, the disease showed initial progression to a peak level, then followed by radiographic improvement, and most of the patients' outcome was discharged. The type 3 had a pattern of radiographic improvement from the beginning. Each follow-up scan is better than the one before, and the patient were discharged. Then the type 2 of patients, they had progressive deterioration despite medical treatment, and many of the patients unfortunately were deceased. So this is an example of the type 3 patient. This patient is a type 2 patient which showed progressive deterioration from day 5 until day 20 of symptoms. So at day 5, initially had some ground glass opacities peripherally located, and then which transformed into a mixed with reticular consolidation and crescent-like ground glass, again peripheral, subpleural, bilateral. So this is a typical case of COVID-19 with extensive lung involvement, which deteriorated much more with an increase of the consolidation and less ground glass, but also the patient had pleural effusions. The patient died 10 days after the final scan. Another patient, which is a type 1, I think, patient. Day 3, the patient had bilateral multifocal consolidations, again peripheral subpleural location. Then this is at day 3 from symptoms. At 7 days after the symptoms, the lesions increased in extent and became heterogeneous, again bilateral, peripherally located, with internal bronchovascular bundle thickening. On day 11, the previous opacification is gone, and the patient shows improvement, and then after 7 days, the lung is much better, and resolution with some fibrotic bands, maybe that we mentioned earlier. So this is a type 2. So initially, there are some findings that progressed to much peaked and then resolved. Okay. Another study also concerned with temporal changes of COVID-19 pneumonia. This is in 90 patients, and they had quite similar results. So the peak illness days was 6 to 11. The predominant pattern was ground glass opacity. The percentage of mixed pattern peaked during 12 to 17 and became the second most prevalent pattern after ground glass opacities. Upon discharge, 94% of the patients still had ground glass opacity as the most common pattern on discharge CT scans. So this is one of their cases. At day 1, there's multiple bilateral ground glass opacities, again peripherally located, subpleural location, posteriorly, and this is another one here. And this ground glass opacity became a consolidation, and this one new here on the left, lower lung lobe. Then at day 11, multiple consolidations can be seen, almost the same extent as the previous image, and then eventually in the last images there's a mixed pattern with ground glass and reticular pattern. The patient was discharged 2 days after this image. This is another 41-year-old woman diagnosed with COVID-19. So at day 3, there's a ground glass opacity, basically crazy paving with superimposed reticular pattern or ground glass opacity in the right lower lung lobe. And after 4 days, in day 7, the opacity has been more extent and increased in size with some lesions on the left also. And day 12, the abnormalities are becoming to be more absorbed, and day 17, almost a clear lung with residual ground glass opacities. This is another case of a 38-year-old woman. The patient, this image is 8 days post symptoms, and you can see bilateral small consolidations, again peripherally located, subpleural, posterior and lower lung lobes. These consolidations increased in size and extent bilaterally after just 5 days. After 6 days. Then at day 19, it became less extent with more parenchymal bands rather than consolidation. And then in the final image, just pure ground glass opacities in the same areas of the previous lesions. This patient was discharged on illness day 30. In the same study, this is a diagram of the changes upon discharge on CT. So the most common was ground glass opacities, next is mixed, and then consolidation, and then normal CT scans. So the 60% ground glass, 75% of it was pure ground glass opacities, and around 20% was mixed with irregularized interfaces, as the examples we have shown. Now, maybe the most important part is, okay, let's say we want to use CT scan to diagnose COVID-19 according to what I have mentioned in the previous slides and the most common findings. But the thing is it possible to differentiate COVID-19 from other viral pneumonias on CT scans or not? So this is one of the most important studies. It's published in just 2 weeks ago in Radiology journal. So they compared the performance of radiologists from China and the US in the ability to differentiate COVID-19 from other viral pneumonias. In this slide, I have summarized what they have found. So these are the most important, statistically significant differentiating features between COVID-19 pneumonia and other viral pneumonias. So first of all, ground glass opacities are much more prevalent in COVID-19 pneumonia than in other viral pneumonias. Lesions in COVID-19 pneumonia had mainly peripheral distribution, while in other viral pneumonias it was central and peripheral. Okay. Vascular thickening was statistically significantly much more present in COVID-19 pneumonia cases than other viral pneumonias. So these three are the most important distinguishing factors between COVID-19 pneumonia and other viral pneumonias. So when in doubt, you can come back to this slide and just read these three or memorize these three differentiating factors. Another factor that has been found to be present in COVID-19 is the halo sign, more than in viral pneumonias, just around 1% of viral pneumonias had it, so it's more prevalent in COVID-19. And pleural effusion, lymphadenopathy, pleural thickening, these were more common, statistically significantly more common in viral pneumonias than in pneumonias. So these features are very important. This table, I think, is very important to have it readily available. Maybe on phone, you can take a screenshot of it or just print it to be next to you. Okay. I will. So now to the main issue. Can we use CT scan instead of PCR to diagnose COVID-19 cases or not? So what the whole fuss is about is this article. When it came out in Radiology, everyone was talking about CT scan is more sensitive than PCR. Why don't we use CT scan to diagnose COVID-19 pneumonia? Since PCR is not available, since PCR takes a long time and has high false negative results, and we need to repeat the results many times. So this is a very respectful article with 1,014 cases. They compared, they correlated the CT changes with PCR testing. Then, following another studies came out. All of these studies are available free access on Radiology journal website, where you can follow this link. Okay. So this is a table. This is courtesy of Dr. Osama from Wuhan. I thank him for giving me the permission to use his table and some of the figures. So PCT has a higher sensitivity and PCR has higher specificity, but what's more important for us, I think, also is the timing of the positive findings. They appear earlier on CT than on PCR, and also the resolution of the positive finding will appear earlier on CT than PCR. So a patient might have changes on their chest CT even though their PCR is not positive, and this is the main thing. And also the changes might disappear, but their PCR will remain positive. Okay. According to the American College of Radiology, their recommendations for the use of chest radiography and complete tomography for suspected COVID-19 patients, they are against using CT to diagnose COVID-19, but these recommendations are regularly updated. This is the latest, I think, 2 days ago. So you can visit their website and keep yourself informed. But again, do we have the luxury that Americans have or Europeans have? Do we have enough testing kits? Do we have PCR available all over our country, Libya or not? These are main questions. I do agree with what they are saying here, that there's a big overlap between many other viral infections and COVID-19, so we cannot say CT is not specific. CT is not specific. It's sensitive but not specific. So I understand their concerns, but maybe we can do what the Iranians did. So Iran has a similar health system to us in Libya, and they are suffering. May Allah be with them and help them. So this is a letter from the Iranian Society of Radiology Consultant Group to the Iranian Journal of Radiology. So they have been using CT in diagnosis of COVID-19 in suspicious symptomatic patients. Also, they prepared a reporting template, which I will show later on, that could be advantageous for classifying patients and predicting which patients should be treated in the outpatient setting and discharged, and which patients require further evaluation and monitoring, and even admission to ICU if necessary. So this is the summary statement of what they are saying, and I think we can use CT in a similar manner to classify the patients which can be treated in the outpatient setting and which can be or have to be isolated. So this is a summary of their reporting template. So they divided. So this template has been provided to all radiologists in Iran, and they follow these guidelines. So there's findings inconsistent with COVID-19 infection, such as trivium blood opacities, central lobular distribution, very bronchovascular distribution, predominantly nodular opacities, cavitations, lymphadenopathies, pleural effusion. All of these are inconsistent with COVID-19. And then you have findings highly suggestive of COVID-19 infection, as we mentioned, ground glass consolidation opacities, bilateral and multilobar involvement, peripheral distribution. I would add subpleural also location, round opacities, linear opacities, which are late finding, crazy paving, which is a late finding, and then the reversed halo sign, which is a late finding also, as I mentioned earlier. So you would have patients who have findings that are inconsistent with COVID-19. Such patients would, especially if they have clinical suspicion, like if they have history of travel or meeting with someone who was positive, we should follow up imaging in case of high clinical suspicion. Otherwise, they should be excluded as COVID-19 infections. Sometimes there's overlap, and I think in a couple of cases there will be an overlap, and then there should be consensus within radiologists, especially the more experienced radiologists. They can decide in such cases and discuss with the clinicians also. If the patient has highly suggestive COVID-19 findings on their CT, isolation until their PCR is done to confirm. So this is good to triage patients. Okay. Now we'll talk about how to report CT scans of COVID-19 pneumonia. I think this is, first of all, this is the, if you remember in the early slides, I mentioned that in the severe disease cases, they would have more than 50% lung involvement. So this is a way to calculate the lung involvement percentage by something called the CT involvement score. This info is from the Radiology Assistant website, which is very, very informative, and I advise everyone to take a look at it. So what they suggested is, for example, for each lobe, when we look at each lobe, we give it points. If not less than 5% of the lung lobe is involved, then it's 1 point. From 5 to 25% involvement is 2 points. From 26 to 49% involvement is 3 points, and 50 to 75% involvement is 4 points, and more than 75% involvement is 5 points. So the total CT score will be from 0 to 25. 25 is maximum involvement, which means more than 75% of all lobes of the lung are involved, and the total lung involvement can be calculated by multiplying the total score points of all lung lobes multiplied by 4, and you will get the percentage of the lung involvement. This is good also for following up the patients. In their follow-up images, we can compare the lung involvement. Has it increased? Has it decreased? And I think it's a very good way also to communicate with clinicians, and it will contribute to a better care of the patient. The standard CT report should have the following information: the duration of complaints, because as I mentioned, there are temporal changes according to the disease stage. We see different pattern on CT, and so the next info is the ground glass and the consolidation. Their distribution, is it peripheral, central, is it posterior or lower lobes, the demarcation, is it round, sharp, unsharp, is there a reversed halo or a halo sign, and then the percentage of the lung affected. And then we should include any other findings such as fibrotic bands, vascular thickening, which is an important sign also to differentiate COVID-19 from other viral pneumonias. Pleural fluid, its presence from not even large lymph nodes, so these will help us to diagnose. What I found is something that I really like, and I think it's a huge effort that has been done. This is a website called Rad2Share, and their aim is to standardize COVID-19 reports. This is a very, very important step, so that imagine if all our reports regarding suspected COVID-19 patients or COVID-19 patients will be standardized, so it's easy to check the follow-up, it's easy to communicate with the clinicians, and also to collect data and to publish research in the future. Okay. So this website, when you go to the website, Rad2Share, the link is in the previous slide. Here I will share with you all the links. Here you go to Corona, then you choose COVID-19. You will find it in a subheading, COVID-19 Standard Report CT. When you press on that, you will find yourself in this page. So first you enter the patient's first symptoms, and then you choose the symptoms of the patient, then you click next, and then this is the admission status, so you choose whatever the patient comes to the emergency room, ICU, clinical or outpatient or unknown, and then the CT protocol. So it has been advised to use a low dose similar to the CT lung screening protocol. It can be it's available on the internet. You can find the protocol. Since I hope not, but since we will be imaging many people, and maybe we will be imaging them many times, it's better that they do not get a high radiation dose. So then you choose what protocol you use, then you click next, and then ground glass opacities, peripheral, central, or none. Next, the consolidations, the same info, margins of the consolidations, you should comment on them just by choosing if there are multiple rounded consolidations, yes or no. If there is reversed halo present, yes or no. And you click next. The predominant distribution, is it upper or lower lobes or none? Is it anterior or posterior? So ventral is anterior, dorsal is posterior. Click next. The pleural effusion. Is it present or not? Lymphadenopathy present or not? Vascular thickening present or not? And then it's time to calculate the CT score that I just mentioned a little bit earlier, so lobe by lobe. But what I like about this system is that it will guide you through while you are looking at the images, so that you don't miss anything. So I think it's more of like a it's a checklist plus a standardized reporting system. So right upper lobe, you look at the right upper lobe, check how much involvement there is, choose 0, less than 5, 25, 50, 75, you choose according to what you see. Right middle lobe, again you choose right lower lobe, then the left upper lobe, the left lower lobe, and then any incidental findings, either emphysema, pulmonary fibrosis, or coronary atherosclerosis, or any other incidental finding. You can type it in, and you just press next. You will get the total CT score, involvement score, which is here. While I was scrolling through the pages, what I entered was 10 out of 10. So for this patient, we would say times by 4, it will give you 40% lung involvement. And now this part is something that I really like. Nowadays it's been there's a shift towards standard reporting in radiology. Maybe the most commonly known is BIRADS. For the thyroid, we have TIRADS. Now we have LIRADS for the liver. There's for the prostate, I think PRADS. So everyone is trying to create a standardized system, which is really good and a very efficient way to communicate with clinicians and also between radiologists in follow-up images, while recording follow-up images. So you choose the CORADs. I will talk about in a little bit the different types of CORADs and what they mean. So you choose your CORADs and you press next. And then the conclusion, is it unilateral interstitial pneumonia on the left only or on the right, or is it bilateral interstitial pneumonia, your conclusion for the whole study. And then the COVID-19 stage, is it 1 to 4 days, progressive, is it 5 to 8 days, peak 10 to 3 days. So according to the main changes that you saw, you choose this to what you according to the changes that you saw. For example, what I showed in the temporal changes, you can go back to the figure of the 4 groups from the Wuhan study of 81 patients. And then after that you generate report. So you get a report, standardized report like this, and you can, if you press copy to clipboard, you can get the text and paste it in a Word document and then just print it. And then if you have many cases, you just reset a new input, you start all over again. So this system, I think, is really good and very helpful because you can use it on your phone, and you only need is an internet connection. I think it's very good. It will keep you focused, and I don't know, I highly advise using this system in Libya, but I don't know if you have any thoughts about it, or if you have any ideas, I'll be happy to discuss. So the CORADS classification, so what they suggest is CORADS 1 is highly unlikely, CORADS 2 is unlikely, and CORADS 3 is equivocal or indeterminate case. CORADS 4 is likely to be COVID-19, and CORADS 5 is highly likely to be COVID-19. CORADS 6 is a known proven by PCR COVID-19 case. So in the highly unlikely cases, CORADS 1, there will be no CT abnormalities consistent with COVID-19 and no abnormalities in the lung, or only abnormalities consistent with non-infectious disease. Okay? For CORADS 2, which is unlikely to be COVID-19, the abnormality is consistent with infection other than COVID-19. If the changes are equivocal and indeterminate, which I suppose a lot of cases will be like that, this is CORADS 3. And then if it's likely, we have abnormalities that are suspicious, that are bilateral ground glass opacities, posteriorly located, subpleural, maybe in the lower lung lobes, either ground glass or consolidations or mixed, all that the changes that I have mentioned, the most common I'm talking about. If you see some of them, it's likely to be COVID. But if you see as a typical picture that I have shown in the case examples, then it's a highly likely case of COVID-19 or CORADS 5. Okay. One point I think is important. If the patient is PCR proven, regardless of their STT abnormalities, they are automatically CORADS 6. So next is the hot topic now. If you open any news outlet or the TV, they will talk about artificial intelligence and its role in diagnosing COVID-19. It's the hype now. And this study published in Radiology also, they found that their AI algorithm can distinguish COVID-19 from other pneumonias, which is quite an improvement. Speaking of AI, Alibaba, the famous Chinese company, they have been investing in AI, and they managed to create a CT image analytics system for COVID-19 with, this is from their website, with an sensitivity of 98% and specificity of 98%, and this is amazing. So the speed they can, a thin section chest scan can be studied in 10 seconds and you get the report. And if it's a thick section CT scan, it's about 5 seconds. What they did, from my research about this thing, I found out that I think many hospitals in China are actually using this system, and Alibaba made it available free for anywhere in the world. And they cannot say it's a diagnostic tool, of course, because PCR is the gold standard. But I think if there's any way that we can contact this company and just send, if we get overwhelmed, I think it's a good thing to have. If we don't have enough radiologists, or we can just send the DICOM files, or just connect our PACS systems in the hospitals with them. But I don't know, these kind of technical issues are beyond my expertise. So maybe if you have any IT people in your hospitals, you can discuss with them this issue. I think it's possible to use it also. So the take-home message from this presentation: the bilateral, peripheral, subpleural, posterior, lower lobes, ground glass opacities, consolidations, also reticular or mixed opacities, vascular enlargement also in symptomatic patients are highly suspicious of COVID-19 pneumonia. Okay. CT scan in the absence of PCR can be a reliable diagnostic method to triage the patients, as I have shown in the Iranian form, the diagram. Okay. Patients with, this is my suggestions. I suggest that patients with CORAS 3 and higher should be isolated and PCR or follow-up scans performed for them. Standardized reporting is a beneficial way to communicate with clinicians and to classify the patients. Proper precautionary measures must be implemented, as I have mentioned at the beginning of this lecture. And this is something that I recommend, that we should have dedicated CT scanners for COVID-19 suspected or proven cases, because in our situation in Libya, I don't think we have the advantage of not using CT efficiently, So these are the references that I used to prepare this presentation. You can just visit the links directly to the articles on the websites. And thank you for your attention. For further discussions, please feel free to contact me on my email, and on ResearchGate you'll find me by using this link, or you can just text me on Skype, and I'll be happy to discuss if you have any comments or anything. Thank you so much.